So when I started in PWS about 5 years ago, really focusing on seeing patients, I've been training for a lot longer than that, so I've been seeing kids with PWS for about 20 years, but really focusing on how do we build a multidisciplinary program for PWS, there's nothing out there in the literature. So I wanted to set up a situation in which everybody could get the same care that they were getting wherever they were going, that people had some kind of a document or there were published papers to say, this is something you should at least think about trying because it's safe. And so that's how I started on this journey. And it did start with a conversation with Dr. Miller because she does a lot of treatments and therapies and has a lot of things in her toolbox that aren't really well documented out there. Started with talking with her and then other experts throughout the country, interviewing parents about therapies they were getting, interviewing experts in the field who work every day with individuals with PWS to really understand what is the breadth of tools that we can use to treat these kids and why does it feel like there's nothing out there to really guide us to be able to do that. So I'm gonna take you through all of that, and that's basically what this says. So I don't have to explain to this audience what usually helps us pick up that a child has PWS, but usually it's picked up in the neonatal intensive care unit, a child who's not feeding well, who also has low muscle tone. And that is the typical thing that we think about when we think about Prader-Willi. But one thing to realize is that that's not true across the board. It is true in about 90% of individuals, but there are people out there who parents have managed at home, they got through the feeding years, they have some delays and still are undiagnosed with PWS. So I know there was also a genetics talk, so I'm not going to go through this in too much detail, but Prader-Willi is caused by missing expression of the paternal critical region on chromosome 15. And this is just to emphasize that, even now we get a lot of individuals who are transferred to our NICU who have had, for example, testing to look for that deleted region of chromosome 15. And families will come to us saying, oh no, they ruled out Prader-Willi, even when they've been, at other medical institutions. And so it really is that methylation test that tells you which genes are turned on in the region that will pick up 99% of individuals with PWS. So how many of you felt like this when you got the diagnosis or during the diagnostic odyssey? And so I can't emphasize enough how important it is for you to take some time at that point to really find your team. You really do. You need to give yourself some time to really absorb what that means. And it's hard not to, when you have kids, it's hard not to think about what does the future look like. And that can be, at a time like this, so challenging to even get past where you are right now. And so I encourage you to really find a support team for you. And give yourself some time. Try to, I know you guys have probably all already done this, but for people who reach out to you, who get a new diagnosis, really encouraging them to just take some time to find their support team, whether it be you that they've reached out to, or whether it be, other experts in the field that you trust, but really allow yourself some time to build a team. And if you haven't done that already, I can't emphasize enough how important that is, because there are good days and there are bad days. And you need that team on good days to brag, and you need that team on bad days to really hear what you're going through and say, I've been through the same thing, or I can understand what you're going through because of X, Y, and Z. And it doesn't have to be someone in the PWS community. I can't emphasize enough how careful you should be on Facebook. One of the most disappointing things about being in the rare disease community is some of the things that I hear that people get said to them on Facebook really make them feel bad. And so I think we need to be more aware as a community of what we're saying to each other. There isn't one way to do things. And there are going to be bad days, and I don't want anyone to ever forget that these kids are warriors. They're determined. They are strong in ways you can't even imagine as parents of young kids. And so they have a diagnosis that doesn't define them, that doesn't limit them. You still should have the same goals that you have for your other kids. But like someone just said to me, it may change what your expectations are for the future, but you should still have those same goals and want your child to get involved in things that they enjoy. It shouldn't hold them back. And so your job as a parent in this situation is to give them all the power and empower them to proceed with the things they want to pursue. So remember, you got this. So I'm going to go through a long list of things. The main thing to remember is that there is no one way to take care of an individual with PWS. We have one thing that's FDA approved, that's a standard of care that I feel very strongly every child should be on, and that's growth hormone. Outside of that, all of this may not pertain to your child, may not be something your child went through, and there are no randomized controlled trials to say that there's other therapies or things that we should be doing right now. So one of the things that there is a lot of literature about, not necessarily in PWS, but particularly in the NICU, would be skin-to-skin care. So, getting the diagnosis, of course, is very challenging. There's high rates of postpartum depression. And one of the things that I really want families to remember is the benefit of holding your baby. Skin-to-skin care really helps with all these things, and this has been shown in the literature to be beneficial for kids with low muscle tone or other medical problems that bring them to the NICU. And bonding is very important. So this also comes back to find your support team, because it's very common for people to have postpartum depression, and you want to recognize that in yourself and take care of yourself so that you can take care of your baby. So I'm going to go through kind of some common things that come up. So undescended testes are very common. Sometimes helps us with diagnosis of Prader-Willi in boys who have low muscle tone. And there is some data that HCG can be helpful, particularly in enlarging the scrotal sac to allow for surgery to be a little bit technically more easy when they go in to bring the testes down. And, we do have some cases where actually HCG treatment is enough that they don't need to go on to have surgery, which is a big deal for these kids who have some anesthesia considerations. So we do encourage people to use HCG, at least try it. It doesn't seem to have any true negatives or huge risks to using it. And then the other thing to realize is developmental dysplasia of the hip is more and more common, and we're recognizing it more in individuals with low muscle tone, and PWS is one of those things. And so there was a recent paper in 2018 that said that we should actually be getting hip ultrasounds on all individuals with PWS at 6 weeks of age to rule out that they may have developmental dysplasia of the hip, because if you catch it early, then you can put something called a Pavlik harness on, which is a brace, as opposed to having to go on to do surgery. So we try to follow this guideline now. The risk of doing a hip ultrasound obviously is very low. It's just like when your baby was in your belly and they were taking a look to see how things were going. So very easy to do, non-invasive, so we are recommending doing it. If they get past that 6-week age over 2 months, then we can actually get x-rays and look at the hips to make sure they look normal. And then, there's a lot of published information about the nutritional stages of PWS, and this is not something that I necessarily say worry about at this age. Did you have a quick question?
Yeah. So that said, to keep doing the x-rays though, should we?
Once you rule out that they have it, you don't need to keep doing it.
Oh, okay.
So I'm just saying, if they haven't had it at 6 weeks with the ultrasound, by 2 months we actually rule it out with an X-ray instead of an ultrasound.
Okay. But if we got to check in 6 months.
Yes, if they won't. No, it's a great question. I'm glad you asked it. Just to clarify, If they don't have developmental dysplasia of the hip and it's ruled out with the imaging, they won't develop it later. Okay, so the nutritional stages are published for Prader-Willi. You know, this is really a loose guideline. This is not every child with PWS follows these nutritional stages at these ages. These are averages, and I will tell you, we do see kids in this age range, the 0 to 2 age range, where they start to have more interest in food and more anxiety around food. And so this is just a rough guideline, but in this age range, of course, as we talked about, you're going to see this failure to thrive. And then we see a lot as kids get closer to 2, usually over 2, that there is some weight gain without a change in appetite or change in diet. And there's mixed reviews about what the cause of that is. Truthfully, from a standpoint of management, I don't know that it matters what the cause is. It could be that they're slowing in metabolism and decreased needs. It could be because these kids have low muscle tone and they move less, and so they burn less calories. It's unclear why this happens, but it's interesting because they always have had that low muscle tone. In fact, over time, the low muscle tone gets better. And so I'm in the camp of thought that there is a slowing of the metabolism, that they have less caloric needs than other individuals. And so it's really important when you're going through all the feeding issues to just remember a fed baby is a healthy baby. A baby gaining weight is a healthy baby. It doesn't matter how they're getting their nutrition. Now, from a bonding standpoint, I know it's very challenging. But, you know, at the end of the day, if you're feeding your baby and holding your baby, you're bonding with your baby just as you would if you were feeding him another way. And feeding difficulties are common. So again, when you're thinking about your support team, people who have been through that, it's really important. There are strategies to try to get your child to wake up more for feeding. Feed them without clothes on. Try different positioning. Try different bottles. And you know, if you're gonna support your child with a way to give nutrition that's not by mouth, we strongly recommend doing it through an NG tube. So we strongly recommend that hospitals become more comfortable sending kids home with NG tubes and training families on them. So if hospitals reach out to us, we say to them, in this case, it is better for these children to go home with an NG tube if the family feels comfortable. Now, if parents don't feel comfortable, then of course, we want to do what feels most comfortable to the families, because like I said, a fed baby is a healthy baby. But if families feel comfortable, we strongly encourage being able to go home with an NG tube. You know, about a quarter of kids still end up with gastrostomy tubes, and that's okay. And you know, there's not, I have to say, there's no data in the literature about what is better. No one has ever done a study where they looked at what really are the safety considerations if someone has the G-tube. How long is too long if you're on an NG tube? How long is too long to feed your child through an NG tube, and are there other risks that we need to be aware of when we're thinking about that? And so this is a video, so positioning is key, and so side-lying position is a position that we use frequently, and so I wanted to show this quick video.
So why don't you turn it that way so I show on camera. So you want his toes and nose in the same direction. Okay. Like he's sitting but sideways.
So even if you're bottle feeding or breastfeeding, putting the baby on the side,
So that his neck doesn't bend back. Okay. There you go.
providing neck support, sometimes providing chin support can help
The
too.
extra flow is going to come out the lower side. So you don't want his nose going toward the ceiling at all. You have to do this little. In this position, if he needs to take a break, he can. Because he's going past the best percent in the fall. He doesn't have any.
So she's saying he can take a break if he needs to, and if he stops feeding, it's not still squirting into his mouth. It will leak out of his mouth, which will allow him not to choke on what's sitting in his mouth.
But you're still trying to do the same pattern he did.
And so sometimes we also, with that hand in the back, we'll have him try to push the jaw forward to help as well. So I think you get the idea. That said, aspiration is really common in kids with PWS. So there was a presentation at the PWSA USA meeting, so an abstract, and then this was recently published to say there's a high number of aspiration events, which means that there's a high number of kids who get some of this formula that goes down the wrong airway. So it should be staying in this, and it's coming down the pharynx right here, which can go into the lung. And that's very common. About 90% of individuals with PWS have this, and actually there was a study by Roxanne Gross that showed that this actually occurs throughout life. So in adolescence too, with Prader-Willi, there's a high rate of aspiration. So what does this mean? It means we need to be aware of it. If your child is sick, we need to think about whether there could have been an aspiration event that could have led to that child's illness, and that could be why they're not getting better. They do tend to aspirate more if they're sick. So kids who have a lot of congestion sometimes end up in the hospital with Prader-Willi. That may be because they're aspirating. And so there's things we can do about this. It doesn't mean they need a tube. It may mean that we need to thicken formulas or liquids that they're getting and just pay more attention to it. The hard part is we don't know how much typically developing infants aspirate, but they probably do to some extent. And similarly, how many of us have been drinking something and start coughing and choking? I mean, that happens to me all the time. So all of us probably have some of these events. And so I think the challenge with Prader-Willi, because of low muscle tone, is being able to clear it. So it's something to pay attention to. Was there a question?
You answered it with this. Have there ever been any kind of comparative study to normal developing infants of how
Okay.
often they're aspirating, or if it's just going unfounded because there's really no clinical problem with the small amounts and with infants that are able to clear their secretions and things like that? I didn't know if there was a comparative.
Yeah, it's another thing that needs to be done. So the other thing to think about is nipple flow rate, and this is from the literature as well, looking at what are the nipple flow rates. And it does show that in kids who have low muscle tone, it is important to consider this. And so this has led to some of the bottles that work really well. And we really like the Dr. Brown's feeding system because, for one thing, there's a valve that you can put in there that will slow the flow, and then you can also take the valve out. So some people, we can change that easily. So if the child's sick and more likely to aspirate, we may say put the valve back in, or when they're really young, they need the valve, but as they get bigger, they don't need it anymore. So that's the one that we like, but there's lots of stuff out there. And then I talked about this already. We have all hypostulated for a long time that there are theoretical risks to having a tube placed. In particular, when you have a tube placed, even when you pull it out, you have a scar there. And as kids, particularly as they get older, if they have a lot of weight gain, weight loss, and they have a particularly large episode where they intake a lot of food, then we think that the stomach might be weaker at that position and that it could be a challenge for that child. But I have to tell you, there is no data about that. When we've anecdotally collected data on the kids who have had rupture, which is rare, very rare, it seems to be there's more important contributing factors than whether they had a G-tube. And so again, a fed baby is best. We monitor the growth curves closely, and we may increase calories. I do recommend that you have a dietitian or a good pediatrician, making sure they're following weight and increasing calories. But we have this group of families coming to us recently who have kids with PWS where the pediatricians are worried they're gaining too much weight, and they're putting them on lower calorie formulas than is safe for a child that age, and they're trying to get them to lose weight as infants. This is not appropriate. So if anybody hears anyone or sees anyone on Facebook or has, please direct them to someone who can really help them, because the kidney is not ready to process that caloric density and the amount of fluids that that child might be getting. So it can be very dangerous for many reasons. You know, all babies have some fat on them, and, you know, there's still other factors for kids with PWS. There's no fat babies. There's well-fed babies, normally healthy-fed babies, and I can't emphasize that enough because I think some people hear PWS, think it starts, the hyperphagia starts from the beginning, and then automatically want to calorie restrict from the beginning. I can't believe how much it happens, and that's something that I really would want to educate people that should not be happening. Reflux is also really common and can contribute to not wanting to feed because things come up, they're uncomfortable, so what we call dysphagia. And so there's behavioral things you can do, meaning not medication-based, so holding kids upright for 30 minutes after feeding, and then medications and maximizing medications may be the right thing for your child. The other thing that I think, again, there's no data, but one of the things that makes us uncomfortable is if your child is getting a tube, really avoid doing the procedure for gastroesophageal reflux, where basically they wrap the fundus of the stomach back around itself to prevent things from refluxing up. And we do think that this is data outside of Prader-Willi, but there is data on this, that it does impact gastric emptying later. So these kids are at risk for slow gastric emptying called gastroparesis, and so we think that this really contributes and could truly increase the risk of gastric rupture. So avoid getting this procedure, even though they will try to get you to have this procedure when they put the G-tube in, because it's a common procedure for kids with low muscle tone. And so we have some nutritional guidelines coming out. Again, our goal with our clinic is really to gather data, so we implement the same thing with all of our kids, or try to. It's challenging, not everybody's the same. And then we try to collect data, and we want to put good data out there in a way that's understandable, that's a step-by-step process to try to help you, but we do realize not everything works for everyone. So as soon as your child has good head control, it's okay to introduce solids. Just make sure that they're in a supportive chair, and there's some really great chairs that actually can also help with preventing scoliosis. And this is one of the ones we like. It is a serious chair, but it does collapse, and so it is relatively easy to travel with. Kids with PWS do seem to have an increased risk of allergies, so you want to give it a good amount of time every time you introduce a new food. So we say 3 days. We don't think you have to wait a whole week, but just pay attention to that piece. And then even from this age, we say really avoid added sugars. So be looking at labels and see if there's any added sugars. And the reason for that is that there was one paper, not a lot of data, that showed that sugar does seem to impact the brain similarly to someone who's getting a drug, who's addicted to drugs. It does light up what we call the reward pathway of the brain. And so that's where that data comes from, that people are worried about added sugars. And then as soon as you start to incorporate solids, you should start incorporating liquid water, plain water if you can. But there's lots of different ways to incorporate water. We try to have people oftentimes make stuff at home, so infuse water with fresh fruits or vegetables. There's also a lot of stuff on the market now. The hint waters, I've had some success with kids liking hint waters, and they have no added sugar, no calories, and they're pretty flavorful if you tried them. The other thing is at this time you should really start to incorporate cups. And so there's different types of cups. We often start with the honey bear cup, which really allows you to help the child get the fluid through the straw, but it also really is great because it starts to get them used to what the technique would be, what you're trying to accomplish, to learn. And then the other reason we say incorporate a straw cup early is that it is tremendously helpful with the low muscle tone in the cheeks and the muscles of the face, and helps with them chewing later. So one of the things we like to emphasize is make sure your child chews well because of this aspiration risk, and so using a cup with a straw early helps them develop those muscles. And then I have a whole lot of stuff that I'm going to provide all these slides for you guys so that you have kind of some of our guidelines, since they're not out yet, of kind of our philosophy of how to introduce foods. Solids, we'd like you to start with non-starchy vegetables. So broccoli, celery, all of this is pureed though, nothing solid. But fruits, there are certain fruits that are better than others because they have a lot of fiber. So typically berries, avocado is great if your child will eat it because it has a lot of medium chain triglycerides and good fat. And then if you're gonna do, we want you to do proteins. Again, everything should be pureed when you're first starting solids, but really focusing on lean meats. Okay, so supplements is a whole talk in and of itself. And so there is very little data to say we should be using any supplements in PWS. So what we typically have families do is, if they're interested in them, we do encourage people to try them because we want to do anything that could be beneficial. We say don't ever start 2 at once, only start 1 at a time. Try to systematically collect data about whether you think that's helping your child. Most of your children are in therapies, which we're going to talk about is very important. Ask the therapist, don't tell them that you've changed anything you're doing, but ask the therapist, tell me if you notice anything different about my child. Do you think anything, especially physical therapists, like if it's something that should impact muscle tone, ask the physical therapist, just tell me if you notice anything different. I've been noticing, I thought maybe this was better, but I want you to tell me what you think. Or don't prime it like that actually, but try to collect systematic data and see if people comment, because you don't want to end up with your child on 40 supplements that you have no idea are doing anything. That's not a good thing. I mean, it means that they're taking a lot of stuff into their body that we don't know if it has benefit. We also don't know if it has risks to it. They're taking a lot of things into their body that then don't taste good. So a lot of times they're developing maybe aversions to certain things that can make it challenging. So these are real considerations. So you're going to hear, there's a ton of them out there. There's probably some of you could name 20 more, I bet. But these are the ones that we hear about a lot. So the basis for use of coenzyme Q10 is that there may be a problem with the powerhouse of the cell. So there may be a problem with the function of part of the cell called the mitochondria that is really important for the production that our body uses for energy called ATP. And so coenzyme Q10 is part of that chain of events that allows that part of the body to make energy. And so that's theoretically where the benefit came from. There have actually been some studies that have looked at levels of coenzyme Q10. For the most part, they're normal, so it doesn't seem that there's a deficiency in this particular vitamin. And there's a little bit of data that it may impact development, so it may impact primarily motor development. And so there was one study that looked at kids who were on growth hormone versus coenzyme Q10. It seemed to have the same benefits as growth hormone in that one study. We do try it. A lot of people have different philosophies about dosing. We typically start at 100 milligrams to start, but then some people do milligram per kilogram dosing. And there's no randomized controlled trials to say that this is beneficial. And the side effects are that it can cause reflux. So you need to be really aware of that. In a child who's not feeding well, one might prioritize getting the feeding under control before they incorporate something that really makes reflux worse. Carnitine is similar. It's important for how our body gets energy from our fat to our muscle. That's simplified, but that's how I'll explain it. And there's some conflicting data about whether there's low carnitine levels in individuals with PWS, and I think that is something that's worth checking or having your doctor check, because we are seeing that some people have low levels of carnitine, and in that case, absolutely, it should be given back to help your child. It may be helpful for alertness and daytime energy. And then there was a paper that came out from Art Baudet's lab that showed that maybe carnitine plays a role in non-syndromic autism. So that kind of renewed some interest in this particular vitamin as well, or supplement. And so this is the dose that we're typically using it. And again, no randomized controlled trial of actually using this in Prader-Willi. MCT oil is medium chain triglyceride oil. It's really helpful in augmenting some of the diets that we do recommend. So higher protein, higher fat diets, no added sugar, less carbs or non-nutritious carbs in the diet. And there's been actually some recent papers that MCT may impact ghrelin. So of all the supplements, MCT maybe has the most data to suggest that it may have some mechanism pertinent specifically to PWS, although there's no trials of MCT in PWS. And so there's a lot of data about MCT also in the overweight and obese population, not the hyperphagic population, but the overweight population, that it may be helpful for appetite. And it is definitely a source of fuel for the brain, so it may be helpful also for that alertness. And so this is something that we are trying and recommending. B vitamins are really hard, in particular B12. So individuals with PWS across the board have high levels of B12. If you check them, I mean, we checked them in a lot of our patients. It's not published, but they're in the thousands, even though parents don't have their kids on any supplements when we're doing those levels. So there was this school of thought in the community that maybe they don't have enough active B12. There is no data to support anything like that. And so it's hard because a lot of people are interested in getting injections of B12. B12 injections are a little bit different than giving growth hormone injections. B12 injections go into the muscle, and it's a volume you have to give your child into the muscle. So it's a little bit different from the subcutaneous injection that growth hormone is down to a science in giving. So it's just something to consider. It's something where we definitely need more data. We certainly see patients who are on it, and if they feel like it's helping, we encourage people to continue it. The levels in these kids who are on it are in the 100,000s. They're really high, and I just don't know what the impact of that is. So, it's one of those things, risk benefit. We don't feel as comfortable using B12 in our clinic. DHA is one that has a lot of data out in the literature about its use in neurodevelopmental disabilities, autism, and there's some good studies that show that it could help with neuropsychiatric development. So we do encourage use of DHA or using a formula that has DHA and continuing a milk, or that has DHA when your child turns 12 months. We recommend transitioning to whole milk. And so that's something that we do recommend. And so we do recommend children be on a multivitamin, and so there's some good multivitamins out there. And in particular, if you're using only breast milk, you do want to make sure that your child's on vitamin D. So there's a huge body of research going on in terms of the microbiome. And what does the microbiome look like in PWS, and does this contribute to some of the features of PWS? And there's still a long way to go in terms of research in this area, not just for PWS, autism, other neurodevelopmental disabilities. So we think that the gut microbiome play a huge role in the development and function of the central nervous system. There's not overwhelming systematic data to say that's for sure, but there's enough suggesting that that could be the case. And so there's probiotics out there that try to reestablish the gut flora. So there are all the different types of bacteria you might have in your gut that you take as a powder form or a pill form to reestablish a new colony. Then there's prebiotics. It's kind of like fertilizer for those bacteria. So it's food for them to try to encourage the healthy type of gut microbiome to grow over the not as good. So there's a book that came out of someone who's interested in autism, but again, there's no systematic study to say this is what we should be doing. So, we encourage people to be on one or the other. Some people are on both because it does seem to help with keeping things going through the gut. So constipation, it does seem to be potentially a natural way to help with constipation. But this is another area of we just don't know. Early intervention is key. I guess I don't need to tell anyone in this room that. One thing that's really important is a feeding consultation, and we encourage everybody to do a feeding consultation. Getting involved in state programs is really important. And then you also just really have to do a lot of advocacy, because a lot of the state programs will say your child's in developmental therapy, and they stay in developmental therapy for months and months and months, and they don't progress to physical therapy. They don't progress to specific types of therapy. So, we want kids in PT by about 3 months. And, it is important to meet kids where they are in terms of their physical therapy. So, if a child's just starting to hold their head up, we don't recommend just taking that child and working only on sitting. You should try to slowly and work through things. That said, there is no regimen or program that's been studied to say that there's any risk of scoliosis. You have to be comfortable with the providers who are providing your physical therapy. Lots of things with balance balls. We definitely think it's so important to build core strength. I can't emphasize that enough. You need someone who will think outside the box about how do I build core strength. So balance balls can be fantastic for these kids. But there's no clear evidence to say, if you do it this way, that is why your child has scoliosis. And so we need to be careful about putting that out in the community, right? Because that's where families feel like, I listen to my physical therapist. I have families come see me in clinic in tears, saying to me, I put my child in physical therapy. I trusted this physical therapist, and look, my child has scoliosis. It has to be their fault. They were sitting my child up before they were ready. That's bananas. And makes parents feel awful. So bottom line is there's no data to suggest that. You have to have someone you feel comfortable with. If they don't work well with your child, yes, switch. We advocate for these kids to have the best therapies. We're on board. But if you like who you're working with and your child's making progress, most likely the scoliosis has nothing to do with it. They have Prader-Willi. They have a high risk of scoliosis. They have low muscle tone. They have a high risk of scoliosis. The other thing is OT can be really important for some of the sensory things very early on. So exposing your child to lots of textures and working with someone who's familiar with that, who again will think outside the box about what can we do? Are there suits that we can put on these kids that will provide some stimulation so they can focus on other things? And then speech is really an important piece. A lot of kids don't talk till they're older, and that we think that that's because of something called apraxia. So it's in there. Cognitively, they can speak. They want to speak. It's a problem with motor planning. So if that's the case, one of the families that I work with about 5 years ago, actually in a different community, told me their child started prompt speech therapy. The mom's actually working on a book because it was life-changing for her child. So prompt speech therapy, which has to do with also working with the child, manipulating the mouth, helping with placement of the tongue, communicating in multiple different modalities. So, using hand gestures and talking to the child all can be really helpful. And then we've had a lot of people go for neuromuscular electrical stimulation to help with swallow. There's no data out there. I don't know if that's one of those things that if parents want to try, they pay out of pocket for it. It's not something we recommend necessarily because it's basically providing an external stimulation to the pharynx to help kids with swallow. And then, yeah.
Sorry.
Yeah.
I have a couple questions. Where would we be able to obtain that Dale study off of prompt? Like my little guy's been in prompt since he's been 10 months. and it's been great.
Yeah.
But again, like when I was asking my speech therapist, she's like, oh, I would love to read anything. She is prompt
Mhm.
trained. But she's like, I would love to read anything you have on it. Will you ask when you go to the conference? So do you know how to obtain that?
Yeah, so if you email me, I'll send it to you. Yeah, it's an article in the literature about prompt. It's not for PWS, but it's for other communities that there's been some published data on prompt. There's also some great YouTube videos if you want to learn to do prompt with your child. I watch them and I sometimes work with, if I have time, can even just try it in clinic with families just to kind of give them a sense of what it is because it's pretty easy to learn. Was there another question?
We've heard a lot of conflicting data as far as timing of when to start speech therapy. So I just wanted, I know the slide says by like 6 to 9 months, but we've also been told that kids that aren't walking yet are really gonna focus on gross motor before they move on to speech. So I'm just kind of curious, you know, what your stance is on that.
Yeah, I don't recommend waiting. Yes, that's true. Some kids do focus. That's very common. In fact, some kids won't make as much progress, but still working with them and getting the skills, I think, are very key. The other thing is that a lot of kids need speech therapists for the feeding aspect, and it just depends who does that piece. But yes, you know, kids have different. Every child with PWS is different. If you've met one child with PWS, you've met one child with PWS. And so some kids have more limitations in terms of developing their motor skills, but might cognitively be great and ready to talk. You don't want to hold anybody back by waiting.
We struggle with that in the community of trying to get her actual speech therapy when our therapist wants to focus more on feeding and saying, oh, we'll do that more towards 18 months. I'm like, no, I want to get that initiated now.
Yeah.
And it's kind of seems to be a theme in our community of lots of waiting to certain times, waiting 18 months for this, 24 months with this, when we're really trying to push for it at a much younger age. So anything that's ever put out there is like to help would be great.
Yeah.
Because it's going to start these therapies earlier.
Yeah. So is that your daughter talking?
No.
Making noise? Someone in here is making noise in this. Yeah. So if your child's making noises, they're ready for some speech therapy.
She's starting next week, but she's gonna be 2
Yeah,
in
awesome.
December. And we got
Yeah.
the same thing, that they wouldn't even consider her until 18 months, and then we finally got the appointment for the event. It's been a process, but it's gonna start at 21 months, 22
Yeah.
almost.
And our daughter's the same age as her, and she makes a lot of the same sounds. So
When did she start?
making sounds and babbling, probably a few months ago.
Okay.
Samantha makes sounds, but she also makes mouth movements, and there's not much.
Yeah,
in
so
the mouth. That's where I feel like we have.
that's
the apraxia,
apraxia.
where She'll mouth mama, but there's no voice behind it. She's just now starting to do it. She said mama yesterday for the first time, but for weeks she would be like, the mouth
Yeah.
movement would be there, but no voice behind it.
Yeah.
Can I add something to that? So what we had, our speech person did feeding and speech. And part of the feeding piece of it is the different foods that you feed them helps them make new
Yeah.
sounds.
Mhm.
So the more you feed them, the more you go through that feeding process, the easier those sounds are gonna come. So like the feeding is definitely really important to continue doing.
She
Yeah.
gets a variety, and she
Yeah.
gets everything toes, like she gets variety.
Let's have one more question, and then we'll pause this.
Yeah,
for
yeah.
finish your presentation,
Yeah.
and then we can, but go ahead, you've been waiting.
Gurgling,
Mm-hmm.
oral muscles with a lot of gurgling in the back of the throat. Is that lack of muscle, or what is that?
That is probably from the low muscle tone. You have to pay attention to when that's happening. If that's happening after feeding, they're aspirating a little. And has the child had a lot of infections? No? Okay. So you have to pay attention to that because, it's stuff going down the wrong way and then taking them a little while to clear it, and that's them working on clearing it. I would think about thickening things a little bit, liquids that they're getting, just thickening a little bit just for a period of time, and then seeing if that clears up a little. Okay, so behavior is really normal in this age range. So that said, every parent, and as a parent I can say this is really hard, having young kids, but every parent though should teach the not right way, but teach praise, be proud of your child no matter what it is they do, no matter how small the accomplishment. Kids with PWS are people pleasers. They want to make people happy. They want to make people proud of them. So the more praise you can give, the better. Rewards, even, probably not until about 18 months, so a little bit, towards the end of this age range that I'm talking about. But reward charts work really well. Competitive reward charts work really well. So if you have other children, having a reward chart with number of stickers for all the other kids and doing the same things as you do for your child with PWS as you do for other kids. And, start to pay attention to rigidity at this age. Now, they're going to be stubborn. They're going to have tantrums at this age. That's going to continue for a few years. That's normal. So, there's a balance, but you do want to be paying attention to some rigid behaviors you might notice, communication concerns, not making eye contact. And the reason for that is that not because anybody wants to label the child or put any diagnosis on them. We want to help them. We want to help them develop those skills. So when we notice that there might be some concern, we want to get in there and get them the right therapies. And sometimes that requires the right ICD-10 code for the insurance. And that's just the reality of what we do in medicine. I constantly am finagling and, working on that. And shouldn't have said that was being recorded. But, we do what we have to do to get the kids the therapies they need. So these are things to pay attention to because we might be able to help. And then I can't emphasize enough to do the normal things you do with your other kids. Gymboree, all the Mother's Day out, all of the activities you would do with other kids this age. You want to do that with these kids too. And don't feel bad for putting your child in daycare. They do not need a nanny. They can go to daycare like other kids. At some point, your child's going to go to school, and they're going to be exposed to all the same things that they might be exposed to when they go to daycare. So don't feel bad about having to put your child in daycare because they may have special needs. So, and I can't emphasize this enough, is that the only standard of care we have for Prader-Willi is growth hormone. We recommend you get your kids on growth hormone right off the bat from birth. We have a protocol in our NICU. We get kids now growth hormone in the NICU. During pregnancy, the growth hormone is made in the placenta, and the child does not have any growth hormone at birth. If your child has PWS and they're not producing growth hormone, then they don't have any growth hormone right from birth. If your child makes some of their own growth hormone, which many kids with PWS do make some of their own growth hormone, in fact, a lot of them do, then there are still all these other benefits of growth hormone that we know about in this population. So we want kids on growth hormone right from the beginning. The problem is there's very little data about this. The data really goes down to there was a recent randomized controlled trial, though, in kids less than 24 months to try to help with this, but those kids were closer to 1. But it did. It showed that it's safe. That's the number one thing we worry about. Is it safe? It is. That trial showed that it's safe. It also showed that it has some benefits at that young age. So we want to get kids on growth hormone right off the bat. It also there are some data coming out now from multiple different labs that are showing that kids may have some IQ improvements on growth hormone. And so we are recommending as early as possible that you get on growth hormone. The biggest challenge with growth hormone is sleep. And so there's sleep apnea, sleep disorders are all very common in this age group. You can see that there's CSA is central sleep apnea, and there's also obstructive sleep apnea. And so the FDA requires we get sleep data on these kids. So what we're doing, and this is not, and the FDA is accepting and insurance companies are accepting, if your child is in the NICU, which a lot of kids with PWS are, and they're on a monitor, that is enough for your first sleep study. So we can get kids, if they have been in the NICU a week, with enough data to say they had that first sleep study. So we can get them on growth hormone. Then you still need the follow-up evaluation, and kids do tend to have more sleep apnea from that evaluation, on that second evaluation. There's data in adults to say that growth hormone has no impact on sleep apnea. There's no data in kids. I suspect that the bigger concern at this age is the low muscle tone that's contributing, and here's the difficulty with this, is that the growth hormone actually helps the low muscle tone, which helps the sleep apnea. So there was a study from Dr. Miller's group that showed that a lot of people got better when they started growth hormone in terms of their sleep. So what we recommend is that we send you to an ENT. We try to continue the growth hormone in our clinic. We fight really hard sometimes, and we have some discussions about it, but we try to continue growth hormone in our clinic. And then we do send you, and the gold standard now is to do a drug-induced sleep endoscopy to look to see if there's any surgical intervention. But most of the time in the age range that your kids are, there's not that much we can do about it. They don't have huge tonsils yet. They don't have huge adenoids. So it just requires that discussion and balance. Central sleep apnea is also really common in this age range. It's basically your brain doesn't have the normal drive to breathe. And so the only treatment for that would be to go on oxygen. Sorry, I'm rushing because I'm almost out of time. I want to have plenty of time for questions. Scoliosis, when your child can sit up from lying down to sit up on their own, we do recommend getting an x-ray of the spine just to look. That's because we miss a lot of scoliosis in these kids, because it's hard to see because of the low muscle tone, but also because sometimes all we see is a tiny bit of asymmetry in the shoulders, and that's hard to see. So we do recommend getting an x-ray of the back. Constipation is really common. It's under-recognized too. If you're noticing your child ever gets a balloon belly, gassy, it's most likely that they have bad constipation. We've had several parents come in and say, look, my child poops normally, and we get an x-ray, they're totally backed up. So in PWS, this seems to be really common. And so keeping them on some of these supplements, that's where MCT does have benefit. It helps keep things moving in the gut. So that may be something, but you want to be aggressive about treating that, because it's a risk for kids to reflux and aspirate. So it can cause a lot of problems. Allergies are common, so we do recommend getting evaluations for allergies. And then they do have really thick saliva, and they don't have the right salt content in their saliva. It doesn't coat the teeth. So kids with PWS, even at this age, start to get cavities. So the American Academy of Pediatric Guidelines say these kids should be getting evaluations of their teeth every 3 months, starting at age 1. So it's really hard to get the dentist to listen, but it's in the guidelines. So I encourage you to take those guidelines, which are widely available online, and show them that that is necessary for your child's medical care. So oxytocin, I could spend a whole lecture talking on oxytocin. There's some data that oxytocin might be beneficial for a couple of things. One of them is feeding, so early on. The other thing is bonding with parents. So social aspects. As kids get older, it may have other benefits for social behavior and hyperphagia. In Europe, they're a big believer in using this. Dr. Tauber's group is using it widely. I know people are getting it in the community widely. It's something, number one, at the doses that we think are right to use it from the most recent studies, which would be 4 international units in 1 spray, we think it's definitely safe. The studies that have showed that it's not safe have been using really high doses. So doses as high, I think I put it on here, but as high as 48 units a day. That's more than 10 times what most people are using right now. So in those studies showed that it may increase the risk of aggression in older kids. So it's one of those risk-benefit. It's widely available. It's one of those things that if it's really beneficial at this age, we don't want this group of patients to miss getting it. We feel like if there's data to suggest something's helpful, but most importantly, if there's data to suggest something's not harmful, Of course, we don't know long-term what that looks like. We want to help people who are interested and have educated themselves. The challenge is there's no consensus on whether it needs to be redosed, and all of us have a little bit different school of thought about that. How many of you redose your growth hormone every day? Anybody in here give growth hormone every day? Yeah. Growth hormone is a hormone that our body produces. Oxytocin is a hormone our body produces. If the hypothesis is that our child does not produce oxytocin, then why isn't it something that they need every day? We know that people produce oxytocin throughout life. So truthfully, we don't know what the benefits are truly in Prader-Willi. Lots of people are working on that. I have some flyers for a study, not necessarily for this age range, but people are really trying to learn more. But the bottom line is, everything we know about oxytocin outside of PWS says it's produced throughout life. We're saying our kids don't produce it. So everyone has a little different school of thought about this, but I think it's a lifelong therapy if we're saying it's a therapy for PWS. It's not a one-time therapy. So it depends what the benefits are, but you can see from these studies, these are benefits that affect people throughout life. Social behavior affects people throughout life. Cognition, everyone would agree, affects people throughout life. So we're not sure what we should be doing with it, but it's out there and if you have kids, you want your kids to get everything. You want to do everything you possibly can for your kids. So we feel that way about your kids too. So that's where we are on the data.
Is the cortisone study that starts later, is that an everyday thing that they're doing? Is the dose every day?
It's a dose every day from what I understand. Does someone? Yeah.
But continuously.
Continue. Yeah. Continue. Yes. Okay. So we have a multidisciplinary clinic at Vanderbilt that we're very proud that we're able to bring together all these specialists to see you. So if you come to see us, I'm just a very small part of that team. We think it's important that we all sit down and have a conversation about every individual and make sure that we're doing what we all feel comfortable with, that we all think is right. And so we do have a paper out, and the only reason I'm mentioning it is because it can be helpful to take to your doctors. We talk about growth hormone, we talk about oxytocin. Some people have been able to take it to their local providers and get them interested enough to help their child get oxytocin. So, questions? Okay.
My one question is, now that there are some babies that are turning 1 and 4 that had access to growth hormone within the first 6 weeks of life, is there a way to do a retrospective review of those children versus other children and see how they do at years 1, 2, and 3 to show, hey, these are the differences. This is the difference between a child that got it at 6 weeks versus a child that got it at 6 months or even 16 months.
Yes,
it's something to consider.
It's something that we have considered. It would be really important to get all the centers involved in that because there's only so many diagnoses a year. Although we learned at the scientific meeting it's probably in an incidence of 1 in 8,000, which is more common than we used to think it was. But we got to get everybody on board to do this, to be a participant in that study. But it's really important to do, and even if some places publish case reports, yes, it needs to be done. It's something we've thought about.
And to add to that, PWS Global Registry is a place where we can do that kind of more organically. So you can put in when your kids start growth hormone, and we can start gathering data on long term. So please, 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 everyone in this room needs to register for PWS Global Registry.
Mm-hmm. That's really important. The problem is needing the numbers, and so the more people that are in the registry who indicate that they got growth hormone early on, the more information we'll have. Yeah.
I just know the biggest challenge when you're in the infant groups and you're seeing the parents of the newly diagnosed, unless they have access to your clinic or one of the other Prader-Willi clinics, is there's months and months of delays of getting on growth hormone. Not even just because of insurance challenges, but because you have physicians and even endocrinologists who don't see the importance of it and don't consider it. And
There's an article out that just came out though for less than 24 months, a randomized controlled study. That's a good study that showed that has benefit. Now that's to 24 months, but it's a good start for people to start distributing so people have it. Yeah.
I think a lot of
Yeah.
the studies I've seen say under
Trying to
one.
find the reference.
So the NICU unit was just like, oh, as long as you make an appointment by 6 months, as long as we get it in by 1, that's what the research shows. So they don't see the need to hurry up and
Right.
do that.
I was trying to find the reference.
And the NICU babies also that have been on the monitors, right, they'll still discharge them and say, oh, we'll go get a sleep study, which will be scheduled 4 to 6 months out after they've already had their appointment, which is also a delay. And then, it's just, so a lot of these children are not starting until 6, 7, 8 months. And
Yeah.
through no fault of their own.
So this article came out just this year in March, I think. So if anybody emails me, I have my email everywhere in this, and if anybody wants to get in touch, I can send you the article. But yeah, there is data coming out. We realize this is important. Yeah. Yeah. Go ahead.
I
Yeah, it's looking for you.
a question about the oxytocin. This is the first time I've actually really heard about it. I know there were some studies, but is this something that I need to go because of all these delays to advocate to get now for my child? Is that what you were saying in the last slide?
This is a great question. If, we think it's right now what the data has shown, and there's conflicting data that it's helpful maybe for feeding. It wouldn't be wrong to try it because it has some benefits for particularly anxiety, which we see manifest in ways we don't even notice at this age. So it wouldn't be wrong to try it. And see if it makes any benefit. And what we do is just do a 5-day trial, and we try to get people to collect systematic information by other providers who see the child, so that we can try to collect data about whether it's helping. But it's something that it's something you could try. Is it magic? Is it gonna harm your child if they don't get it? I don't think so, but it's worth trying if you're interested.
We do it, I can talk to you about it.
Awesome.
Yeah.
And I have one more question. I'm so
Yeah.
sorry. How often are we supposed to increase the growth hormone? And what levels, or are there levels or weights that we're looking for when we want to increase the dosage?
That's a great question. We do it primarily based on the IGF-1 level, which is a marker of growth hormone circulating in the body. Growth hormone is diurnal, so it only gets released primarily in the evening, so certain times of day it gets released, and so we can't capture it well unless we do a stimulation test. So we look at a surrogate of that, which is IGF-1, which is more stable. There's another marker called IGF-BP3. It's very influenced by the child's weight, but some people recommend doing a combination of IGF-1 and IGF-BP3 and looking at the ratio of the two, because that gives you a better sense of the active form of growth hormone that's circulating, truly active growth hormone. And people think that using that along with the IGF-1 will help you better to figure out dosing, but it's all based on the IGF-1 level. There is a clinical sign that kids need growth hormone. So oftentimes if you notice fat pockets at the wrists, ankles, that's an indication that your child might need to increase their growth hormone.
Along those lines, I have a couple questions. Along those lines, when they give you a range, like children ages 0 to 3, the range is between 15 and 125 for IGF-1s. This is a range of normal. Where do we that's a huge range.
Yeah.
So like when my kiddo his IGF-1s were coming up at, even on a 0.1 dosage of gymtropin, it's coming up as below the range of normal, they increase. Well then he's, if he's on that for a month or two and he's still clocking it at 16, I had to push to say, hey, we want an increase. And then every month for 6 months, it took it until we could get us to a healthy range. Where do we like to see kiddos in that range of healthy, because it's so broad?
So it depends on the age, but in the infant period and the early childhood period, we try to run them in the normal range, but on the high end of the normal range, because of the reason I just talked about, where the amount of circulating active growth hormone may be lower in these individuals, particularly if they truly have growth hormone deficiency, than someone who you can just measure an IGF-1 level with. And so it becomes a ratio, and the number is actually falsely higher. Yeah. Go
Is
ahead.
that the same for UPD and deletion? Because I know that there's been some chatter about UPD not needing quite as much because of some insulin levels and things like that. I don't know if you've seen that, but
I'm not aware of that data, but
I can forward it to you. But.
you know, it's the same. You know, I don't know that I've ever looked at or seen anybody pull out whether they're more likely to have growth hormone deficiency if they have a deletion. But yeah, and Dr. Kimonis is shaking her head. No, she knows a lot more than me about that. So I would say no, that it's the same dosing. We want to run them slightly in the higher range, but still in the normal range. And anybody who we see, I'm not the endocrinologist in the clinic, by the way, but anybody who we see who is above the range of normal, we will cut back very slowly on growth hormone. So we think outside the box a little bit. So we'll do 0.5 higher dose one day, lower dose the next day. But, you know, we won't, if we're going up on it or if we're going down on it, we'll do something like that because we know that it can change dramatically very quickly and we don't want to overshoot or undershoot. So it requires something outside the box, but no, not that I'm aware of. Would there be any different way? Yeah.
My question's about sleep quality. My baby's 2. We've never had any sort of abnormal sleep study before or after growth hormone, but I am concerned about her sleep quality. When do you recommend getting with a sleep neurologist who more monitors if they're getting good quality sleep even if they're staying asleep?
So that's a really good question because one of the things we even start seeing as early as this age is some signs of a narcolepsy, cataplexy-like clinical picture. Now, if you saw the data from the clinical trials discussion this morning, it's not quite narcolepsy and we know that, but we can see signs of that and that can impact quality of sleep tremendously. So we start talking about it early on. The challenge is that I'm not sure that there's, besides routine with sleep, I'm not sure that there's anything we would do this young. I didn't talk about this at this age range because I've never started modafinil this young, but there are medications that are approved for narcolepsy that do seem to have significant benefit. We usually wait till 5 or 6 to think about those. So I'm not sure that there'll be anything additional we would do.
So maybe wait till they're a little older to start pursuing. Okay.
Yeah, but it could be that they don't get good sleep because of that. You know, one of the things we do see with starting solids in kids who have probably a cataplexy-like picture is this, what looks almost like seizures when they're eating, like this head drops, they seem like they're really almost enjoying the food and it gets them excited and they fall asleep for a second. That's a sign that they're gonna have that narcolepsy, cataplexy. And so we hope when your kids are older that we will have some wonderful treatments for that because there's lots of great things coming.
You said it's about 4 that you can start treating because we experience it now.
Yeah, the head, we see it this early. I've never been comfortable to start, because these medications are stimulants. I've never been comfortable to start this young. But yes, we see it early, and maybe some of the things coming along the pike will be available this early.
Would having the data, even before you're comfortable treating, be helpful in because it looks different than your traditional narcolepsy?
Yeah.
Would be able, I know my daughter has cataplexy. I see her when she gets excited about eating something, her eyes are red, you know.
That's
and so
exactly.
would it be helpful to have that long-term data to say hey look, we have this. It doesn't look like your clinical picture might look for this traditionally, but we're ready to start. I'm just,
Yeah, I don't think that you're gonna find, I would say I'm pretty liberal in terms of thinking about things and being willing to start stuff. And I think for what we have available right now, number one, you'd never get insurance to cover it, so it'd be out of pocket. But 2, I would never be something I'd be comfortable thinking about this young besides behavioral interventions.
Okay.
Yeah.
In terms of sleep apnea, I'm sorry, I couldn't exactly read the slide, but are you saying with growth hormone, you're generally seeing improvements with the percentage of kids with central sleep apnea over the age of 2?
Yes, growth hormone does seem to help because part of it is the muscle tone. And so growth hormone, more likely to be helpful for the obstructive piece because the tongue flop backs because they have the low muscle tone. For central sleep apnea, they do tend to grow out of it. So, we see it more commonly in this age range, and then as they get older, we see it less and less. If they do have it, the best treatment is oxygen at
We have time
night.
for one more question.
Our daughter has a BiPAP. She started with the CPAP and she's on BiPAP now. And she's been for about a year. And she has central apnea. So I was just curious, even when you say they tend to grow out of it, is there a general age range that may happen?
It's different for different people, but by 5 or 6, we definitely start to see that kids are growing out of it or it's less prominent. But and I'm not a sleep doctor, but we do see that BiPAP and CPAP don't do anything for central sleep apnea. The reason for that is because this is actually a problem with the drive to breathe, which is based on your oxygen and carbon dioxide levels. And the CPAP and the BiPAP more help with the obstructions to keep the airway open. Now, people do incorporate it's hard, but I think there's some, there may be a way to incorporate oxygen into also doing CPAP and BiPAP. But if your child just has to have both or just they should be on, not a sleep doctor, but I take care of a lot of kids with PWS. The treatment's oxygen.
So do you have any suggestions then on how we go forward with this? Because we've been working with Culinary at the Children's Hospital of Philadelphia since she's been out of the NICU. So this is concerning, and this could be why I feel like she's on it, and she sleeps all night, and she wakes up with bags under her eyes, and she's ready for a nap an hour after she wakes up. So now I feel like we've been doing the wrong thing, and I understand you're not a sleep doctor, but I appreciate the feedback. So I'm just kind of maybe looking for like the next best step.
Talk to me after.
Yes.